Chaitra to introduce this topic in neovascular AMD. Dr. Chaitra, we know uh, as a VR consultant from Narayan Netralaya, and she at this young age also has huge number of awards, including very prestigious JM Pava Award for the VRSI. Very few people have won this coveted award. So I request Chaitra to please take over from here and tell us how does she currently manage news for AMD. Over to Chaitra, please.
Thank you so much, sir. I should be sharing my presentation. So,
Chaitra, we can see your slide.
okay.
Carry on.
So, thanks to Novartis for organizing this meet and for AIOS for allowing me to be part of it. Though my topic says my approach to the management of AMD, I think the requirement also is to give an overall view of what is the problem at hand, the extent, and what are the parameters we are monitoring, why we need to monitor them. These are all some important things that we need to be aware of. And that's how I will be covering my talk. So I have no financial disclosures, and a lot of slides have been shared by Novartis because the focus is also on their new drugs that they've come out for AMD itself. So this is how I will be sharing my content about the prevalence of neovascular AMD, the treatment burden, the relevance of fluid, the subtypes and their importance, the AI-based fluid analysis, the variability in the central subfoveal thickness, the drug, the new kid on the block, and some case examples as well. So before I go into AMD and its prevalence in India, the overall globally also it's a huge, huge problem. And by 2040, close to 288 million are expected to be affected by this disease. And you can see the growth is rather steep in Asia compared to the other continents. So coming to AMD in India, we don't have very, very large scale population studies, but compared to when we have two studies that we've looked at, it's anywhere between 4 to 12%. And there is a component of both early and late or advanced AMD as well. So why is there a burden on the healthcare system? It's multifactorial. It could be because of the declining vision in this aging population, and we're having a sizable number of them. The treatment choices that are currently available, the monitoring needs for these patients, because they frequently need to keep coming back to us. The different treatment regimens that are there, sometimes they are taxing on the patients and on the healthcare system, the cost of the drugs itself, the increasing prevalence, as I showed in the previous slides, and also the longer patient lifespan that we're seeing with increased advances in healthcare. We are having the lifespan of patients increasing. So we are having a huge number of aging population. So from the patient's perspective, the frequent treatment and monitoring is really a heavy burden. The reasons being because of the treatment cost, it's time consuming, transportation, and especially with COVID, it's become even more complicated. It takes a long time to travel now because of them restrictions. They're also not very happy with the benefits of the treatment per se, because they do tend to see the cost and the amount of visual acuity gain and the follow-up visits as well. So the quality of life is definitely affected. And when you look at it from a physician's perspective, I think the most important thing was that the monitoring visits are time and resource consuming, and because we need to treat them and again with anti-VEGF treatment, it is definitely a burden from both perspectives. And monitoring as such, we do two major monitorings. One is the patient's visual acuity, and second one is their OCT parameters. We want to also quantify the change. And when we are quantifying, more or less, we are looking at retinal fluid also as an important component. Therefore, looking at the relevance of it in patients with AMD, we do see a lot of pathological changes. And most important, we see fluid accumulation, whether it's intraretinal, subretinal, or sub-RP fluid. And we do know that anti-VEGFs are the ones that is helping us now, monitoring and treating these patients. So when we look at intraretinal fluid, subretinal fluid, or sub-RP, It is a hallmark for disease activity in advanced AMD, and we start, worrying when we see this fluid. So, which is the fluid to worry about? Which is the fluid to treat? Which is the fluid to monitor? I think the two studies, that is both CAT and Pronto, has shown us that SRF was the most common seen in over a third of patients, 3/4 of patients. IRF was seen in 3/4 of patients, and sub-RP was seen in literally half of the patients. And when we're visualizing the retina, OCT has definitely helped us because it not only gives us qualitative but also quantitative. We're able to measure on follow-up and response to treatment. So fluid is considered pathological, be it IRF. These are some examples, SRF and sub-RP fluid. And this is the evidence of disease activity and therefore warrants treatment. And if you look at landmark, clinical trials, fluid has been the key retreatment criteria across all these different trials and regimens as well. And also current society guidelines are looking more at SRF and IRF on OCT as a treatment or a retreatment guideline. And real world also, more than visual acuity loss, it was the presence of fluid, which was the most important indication for treatment and for visits wherein we monitor these patients. So what is the importance of IRF? If you look at it individually, IRF can accumulate into well-defined spaces, and the presence of this is associated with a negative impact on BCVA, and also the residual and new fluid is associated with worse visual acuity outcomes. And when you're looking at SRF, it's a little bit confusing. Some studies show that the presence of SRF at baseline was actually an indicator of better or stable visual outcomes, whereas other data suggests that the recurrence during the maintenance phase could have a negative impact. Therefore, it is important to note that patients where SRF was tolerated are still being closely monitored and treated as necessary to prevent vision loss. And when you look at sub-RP fluid, this is a buildup of fluid between the RP and the Brooks, and only a small number of studies we actually have. And these studies also suggest that changes in sub-RP space could be an early indicator of active or recurrent disease. So all fluid is considered pathological, and they all need to be controlled to prevent irreversible vision loss because they can have a long-term impact on visual acuity. So other than the OCT itself, a more objective assessment or a more automated assessment is using AI. And this is AI-based fluid analysis, and it's shown us that measuring fluid in 3D, whether it was manual or automated, showed good correlation. And when you're looking at volume, there was analysis that has shown that a correlation exists between high disease and low disease activity based on the volume itself. So both all three, IRF, SRF, and PED volumes were all relevant for the visual acuity outcomes, and lower level of any fluid was associated with better visual outcomes. So do fluctuations in retinal thickness actually have any effect on visual outcomes? They do. A higher variability was associated with lower visual acuity gains, and a lesser variability led to fewer visits. So why does fluid matter at the end of it? Because the current best clinical practice states that fluid on an OCT is an indicator of active disease, and controlling fluid is key to effective neovascular AMD management and help in maintaining or improving visual acuity. And the impact of retinal fluid when it is unresolved can lead to worsening of vision, and clinical trial data does suggest that multiple exudative disease recurrences can lead to irreversible vision loss. So now coming to the new kid on the block, brolucizumab. I think all of us now have some experience for the last few months, and it is an advanced single chain antibody fragment, and it has more VEGF binding ability per volume compared to the other available treatment options. It has effective tissue penetration, probably due to a smaller molecular size compared to the other molecules that are available. It also has high retinal exposure, but low systemic in the same way. So therefore, giving us a better safety profile. Now, coming to evidence, I'm just going to cover a couple of studies and go directly to their findings or outcomes. So this is the OSPREY study. It was a prospective randomized double-masked multi-center study which compared it to aflibercept. So just directly into the summary, it was definitely better CSFT reduction, greater resolution of subretinal fluid and intraretinal fluid, approximately 50% of patients receiving treatment maintained visual acuity without any additional rescue therapy despite an interval between treatment. Lower number of additional retreatments even with the 8-weekly, and overall safety profile was comparable. And the phase 2 data demonstrated the potential for long-lasting efficacy and sometimes even extending it to 3-monthly dosing with brolucizumab. The Hawk and Harrier, just a summary, it was non-inferiority was shown here, superior anatomical results, more patients achieved fluid resolution. These findings are consistent with outcomes at 16 and week 48, and most patients demonstrated sustained dryness, and overall ocular and non-ocular adverse events were comparable. Now, this is something that I thought would be interesting. This is early evidence from real world to show that where they actually looked at early clinical outcomes, and it was basically an observational retrospective across multi-centers in the US, and there were also some pre-treatment eyes. What they found was brolucizumab was safe and effective in stabilizing the BCVA in patients who had undergone previous treatment also with other anti-VEGF. So if you look at the change from baseline to the last follow-up, it was a pretty good improvement. And if you're looking at anatomical outcomes, central subfield, there was a significant reduction. The SRF also was eliminated or reduced in 84% of the eyes. IRF was eliminated in close to 80% of eyes, and sub-RP fluid was resolved or reduced in close to 50% of the eyes. No safety concerns were noted in this study. So in the BRUCE study, they showed that brolucizumab appears to be effective in stabilizing the BCVA and reducing the fluid in different compartments in patients who have undergone previous treatment as well. So now going on to some case examples, I'm just showing 3 cases. First one is a 69-year-old gentleman. I think we have close to 8 to 9 years follow-up with this patient, received multiple injections, maintained vision. This is May 2012 across Jan 2014. Patient has also received PDT. August 2014, September 2014. There used to be a waxing and waning once treatment would resolve and then come back. Then again, lost for follow-up in between, treated elsewhere with anti-VEGF, again PDT with anti-VEGF. So you can see the waxing and waning and improvement and again recurrence. This is across. And then again in June 2020, patient came back. You can see here, significant fluid in all compartments. And then finally, patient was maintaining vision, but still was not happy. Since we had the brolucizumab option, gave the patient an injection in 2020, and a week later, you can see already the PED height decreasing. And by a month, there was good resolution of sub-RP fluid here. Patient's visual quality also tended to get better. He was comfortable. This was in March 2021. Again, a slight recurrence. Again, an injection was given in June 2021. So you can see there were subtle changes in the hyperreflective material, and the IRF and the PD also tended to become shallow. The double layer sign grossly remained the same and stable. So this is another lady, 58-year-old, solid PD with SRF. Reloading doses were given, and other anti-VEGF vision was maintaining. But then, there was not a complete resolution, not that we expected in all patients, but, the patient also was not very, very happy. Persisting SRF. Then we gave in April 2021 first brolucizumab, and by May 2021 we did see resolution of the SRF and decreasing PD height. So the second and third injection was also given, and the patient maintained vision. And this is a 68-year-old gentleman, one-eyed, right eye loss, scarred CNVM, and the subsequent glaucoma as well. Left eye had received multiple injections of bevacizumab elsewhere and reviewed in June 2020 at our institute. We did see polyps, and you can see the huge PED there. May 2020 and June 2020 again received injections. Though there was resolution of the intraretinal fluid and subretinal fluid as well, the PED largely remained the same. And again, there was recurrence. We switched the drug. September 2020, second injection was given. Subretinal fluid resolved. PED remained the same. This was this year when the patient presented, again, not very happy, but then sudden increase in the PD height in 20th Feb 2021, and you can also see subretinal fluid there. So the patient received on 27th an injection of brolucizumab. And you can see in about a week's time, the subretinal fluid has resolved and the PED height also has drastically come down. 6th March and follow up on 20th March, 2 weeks after, the PED kept decreasing. We gave another injection, sustained decrease in the PED height, and this was at the final check recently when the PED had completely, at least most of it has flattened. So 3 different cases. Maintenance dose did help in this patient, intended for the hyperreflective metal and the subtle IRF. This patient, poor response to loading doses, but instant response to brolucizumab and sustained response so far. And this was a large, PD, 10 PD. So we were a little concerned, but good response to brolucizumab again with significant decrease in the PD height. So to summarize, all retinal fluid is considered a disease state and needs to be controlled with appropriate treatment strategies. It is imperative to aggressively treat all retinal fluid, and real-world evidence has also shown that retreatment decisions are strongly influenced by the presence of IRF and SRF, and a more stable central subfoveal thickness is associated with better visual acuity outcome. And how has brolucizumab really helped us? First and foremost, it's a unique, small, and a potent VEGF inhibitor designed specifically for ophthalmic use to potentially address unmet needs. The innovative proprietary technology that is used to design brolucizumab has helped overcome challenges associated, and it has also optimized the pharmacological properties to make it clinically advanced in the treatment of AMD. Each 6 mg injection of brolucizumab delivers a 10-fold higher molar dose than the other molecules with the same volume, which has the potential to deliver durable efficacy and thus less frequent dosing. And it has also a high affinity to all VEGF-A isoforms and demonstrates similar potency and affinity to that of aflibercept. And it readily distributes from the vitreous to the retina, where it reaches higher concentration. And preclinical studies have shown that the molecular size being small facilitates better retinal penetration. And preclinical data also indicates that a higher ocular concentration is achieved because of all these particular attributes and also with minimal systemic exposure. So, thank you so much.